Good morning, everybody. Thanks for attending our November meeting of the Informed Prostate Cancer Support Group. I'm Aaron Lamb, your facilitator for today. And I want you to all remember prostate cancer is just two words. It is not a sentence. I hope you are all dealing sufficiently well with coronavirus. Unfortunately, we cannot meet in person as a result. And we are not sure when we will be able to return to meeting in person. But until then, John Tassi will be continuing to live stream our meetings on the third Saturday of each month. Your hosts of the Informed Prostate Cancer Support Group are Lyle LaRoche, our president and director, Jean Van Vliet, our director, Bill Manning, our director and videographer, who does a great job videoing our meetings when they are in person. John Tassi, both our webmaster and in charge of video streaming, such as today's meeting. Steve Pendergast does our newsletter. Hopefully you've all received it by email. If not, you can access them all on our website. They have great write-ups of the prior meetings, as well as new articles of some of the latest findings in the research these days. Bill Lewis, he puts together those detailed meeting summaries, and myself again, Aaron Lamb. Together we have over 500 members, and all of us are volunteers. You can be too. And unfortunately, I got my slides a little out of order here, so let me skip around a little bit. So speaking of volunteering, we do need volunteers. So please feel free to contact us on either the website or on the hotline number. We need people to step up and help recruit speakers, and as well as schedule those speakers. Every 3 to 4 months, we have a panel of gentlemen who share their experience in great detail, and it's a very useful meeting for those of you who have not yet been able to attend one of those. As well as to help take hotline calls. So if you would like to volunteer for any of those roles, please make sure to contact us. The interface on the website, as well as the hotline number, are available for that. Let me just check, okay. Our support to you is through the website that I mentioned. It has all of the archive of all of the newsletters, and our monthly video streaming links. Again, we're on the third Saturday of each month. And the hotline number is also available there. And the hotline is for any of you out there with any questions on prostate cancer, looking for help on what you're going through, please contact us. There's quite a few members that are available to help answer your questions. Because we are we share patient-focused experience to help you become your own case manager. We are a group of experienced participants, and we are not medical professionals. Okay, any sharing by anybody on our group may not substitute for your medical counsel. If you're tuning in, you likely have an interest in your prostate cancer treatment plan and questions you want answers to. We're here to help educate you so you can make informed decisions, informed questions to ask the medical professionals involved with your care. Again, call us on the hotline and we'll help answer those questions. Now, even though we're not meeting in person, we still need your support. We are a 501c3 nonprofit organizations, and donations are tax deductible. We have no medical or religious affiliations. And during this coronavirus pandemic, our costs are still very much the same. We have the costs of keeping the website up and running, as well as advertising to try to get our information into the hands of more men out there. So please make a donation online. You can do that via PayPal on our website or sending a check to that address. And I believe that address should also be easily found on the website. Our next meeting is going to be in January. Note that there's no December meeting since we're so close to the holidays. We'll be having Dr. Munt give us updates on radiation therapy. But as far as today goes, as noted by Director Jean Van Vliet, Dr. Lamb has been the November speaker for our group for many years. As the research director of a group that deals only with prostate cancer, they are often ahead of common practice in finding more applicable treatments for our disease. Today, Dr. Lamb will be discussing the genetic testing and how it's being applied for prostate cancer research, diagnosis, and treatment. And for those of you who have not yet been through radiation treatment, this is what you look like when you come out on the end of it. For me, I had my radiation at UCSD, and they have a bell that you walk by every day that you go in for treatment. And at the end of all your treatments, you get to ring the bell to celebrate being all done. So this was me finishing quite strong through my 2 months of radiation. My secret was digestive enzymes. So if any of you are heading into radiation therapy, please reach out to me, and I'll give you some of the pointers on getting through it. And so with that, I will turn it over to Dr. Lamb. But I should mention, Dr. Lamb will be answering all of your questions at the end of his presentation. But do feel free to use the Q&A of the Zoom meeting, as well as I think there's a live chat interface on YouTube to submit your questions. So go ahead and start doing that, but he won't address them until the very end. So Dr. Lamb, take it away.
Good morning, everyone. Aaron, I like your t-shirt.
Thank you very much.
No, not that one. The one that said, I've been fried.
Yeah. Been there, fried that. My sister bought that, made that for me to celebrate my last day.
That's a good one. That's a good one. And I could see how COVID has affected your appearance a little bit.
Yeah, it sure has. I'm not as presentable every day.
All right, so good morning, everyone. We're gonna have coffee. We should have a Zoom happy hour lecture one of these days. Then we'll have some more interesting. You'll get me with my guard down. All right, so the topic today is role of genetic testing in prostate cancer. This is a blossoming field, and there's almost something new. Every year there's something new about genetic testing, and hopefully, the field will accelerate and lead to some measurable changes in people's survival. So let's see here. Okay, so the goal of today's lecture is to go over some of the roles of genetic testing for prostate cancer. One of the roles, the first role we're going to talk about would be screening to detect clinically significant prostate cancer. Is a biopsy really needed? A second role is primarily once one has been diagnosed with prostate cancer, it will help us make a decision about active surveillance. Genetic testing is also somewhat helpful in assessing one's prognosis after treatment, and also, in fact, guide treatment in certain cases. And then finally, we'll talk about genetics of what we call hereditary genetics, meaning genes that are transferred from one generation to another. So a little background on genetic testing is important to talk about. What is a DNA? And that is the essential thing that we're testing for when we're talking about genetic testing. So DNA stands for deoxyribonucleic acid, and it's basically the building block or the brains behind our being. So it is made up of what we call nucleotides. And there's basically 4 different nucleotides, and they're characterized or basically characterized as either adenine, cytosine, guanine, or thymine nucleotides. And it's this combination of these 4 nucleotides that make up the genes that make us up. So the DNA of us basically, leads to the production of amino acids, and then these amino acids are then put together by our body, by these cells, and into proteins, which are then put together and creates a human cell. And then it takes billions of cells to turn it into something visible, like a prostate, or a piece of a prostate, a piece of a heart. And when all this tissue is put together, it looks like an organ, like a prostate, like a heart, like a finger, like hair. And it's all these organs put together that gives us the host organism. And so DNA, just like it could control the color of our eyes, the type of hair we got, it also gives us a higher or lower risk of cancer. So cancer primarily arises from cells that have that have mutated, and it's not just one mutation that leads to a cancer cell, but it's millions of mutations that are accumulated over a lifetime that then leads to a cancerous cell, and then becomes a cancerous organ, and then potentially metastasizes. And there are 2 types of mutation that have relevance to today's discussion. We're going to talk about the somatic mutation first, which is on the right side of this slide. And somatic mutations arise primarily spontaneously in someone, in the host, for example. And they may be caused by, wrong foods. They may be caused by radiation exposure, some extraneous factor that just happened to the person. And these mutations lead to cancer, but these types of mutations are not something we inherited from our parents, but these just happen spontaneously. Because it takes a series of mutations to cause cancer, we accumulate mutations over time, and then the cancer cell starts. So typically, the somatic mutation related cancers start later in one's life, as opposed to germline mutations, which on the left side of your slide come from your parents. So a cell that your parent had, which made your parent more susceptible to cancer, has been passed on to the child. So therefore, this is inherited, and they typically occur earlier in one's life. So if one has an inherited mutated germline cancer cell, a germline cell, one tends to develop the cancer earlier. A little bit of background before we dive into genetics, just some background on statistics of prostate cancer in 2020. It's estimated that about 192,000 cases will be diagnosed. There's estimated to have 31,000 men die from prostate cancer. After skin cancer, it's the second most common cause of cancer in men. After lung cancer, is the second leading cause of cancer death in men. 1 in 9 will be diagnosed in his lifetime. And currently, there are 3.1 million men in the US living with prostate cancer. And 1 out of 41 men will die of prostate cancer. one thing I didn't put on the slide is approximately 1 out of 10 men who have prostate cancer, their cancer is probably inherited, meaning they got a germline mutation. So 9 out of 10 men at this point, we think they develop prostate cancer via the spontaneous somatic mutations that are not inherited. But as we learn more about the genetics of cancer over time, we might end up realizing 20, 30, 40% of people with prostate cancer inherited some gene that made them more susceptible. A little bit, there's been some changes in as a result of PSA testing in terms of the types of men who are diagnosed with prostate cancer and what stage they are. So before PSA testing, people found out they had prostate cancer usually because of some symptom, or their doctor did a prostate exam and found the big lump. And therefore, before PSA testing, most people who are diagnosed with prostate cancer had advanced prostate cancer. And only about 20% of men diagnosed with prostate cancer back then had the type of cancer that was localized. Since PSA testing in the late 1980s, because the PSA was diagnosing men without symptoms, more men were diagnosed with localized disease, and only 20% of men were diagnosed with advanced disease. And this has some implications. Number one is we've been diagnosing so many men with early stage localized disease. In fact, a lot of these men never needed to be diagnosed, never needed to be treated, and the treatment ended up being more traumatic and impactful than the disease itself. So in 2012, one of the government agencies, US PTF, downgraded PSA testing, saying that it shouldn't be done on everyone. The benefits of testing did not outweigh the risk of biopsies and treatment. And they estimated that you had to screen over 1,000 men to save one person from prostate cancer death. And there were a lot of costs and side effects and from all the treatments, starting with a biopsy, that did not warrant massive prostate cancer screening with PSA. So why hasn't prostate cancer PSA screening make that big of a difference in prostate cancer survival for them to say, don't even do PSA screening? Well, a lot of these men who are diagnosed had prostate cancer that were very slow growing, that never needed treatment. Even cancers that were growing faster, they were never going to be deadly. And many patients were treated, ended up with terrible side effects, and who never needed treatment. And finally, diagnosing people later wasn't as bad as in the past because treatment for advanced disease has improved. So, but the PSA testing it's here to stay. It's there for many reasons. We will continue to do PSA testing. So now that we have PSA testing, what is the goal of PSA testing, and what is the goal for the field in general that we as physicians must ask ourselves to hopefully protect our patients? Well, our goal is really to, once someone is diagnosed with cancer, we have to separate the types of cancer that are not deadly, not dangerous, from the cancers that could potentially affect, cause pain and suffering and potential early death. So the key is separating, I would say, good cancers and bad cancers. And a lot of patients tell me, oh, all cancer is bad, isn't it? Well, not necessarily, especially in the prostate cancer world. So with that in mind, let's talk about the role of genetic testing in men to see if we could determine if a person has cancer that needs to be treated or cancer that doesn't even need to be diagnosed or treated. So the first step is, you see a patient, and maybe genetic testing will help us, number one, decide if he has cancer that needs treatment or not. And then take a step back. As a result, does that patient even need a biopsy? So is there a way can genetic testing help us determine if a patient needs to be biopsied? So typically, when in the olden days, the traditional standard guidelines or criteria that we use to determine who needs a biopsy would be a patient with an elevated PSA, or what we call a high PSA density, meaning the PSA is higher than what we would expect from a person's prostate size, or the presence or absence of an abnormal digital rectal exam, the presence or absence of a lesion or spot seen on an MRI or ultrasound, and even the size of the lesion should have a role in determining if a patient needs a biopsy. And there's some more sophisticated PSA tests that we've incorporated, and they're not genetic testing, so we won't talk about it too much today, but I call these super PSAs, meaning they give more information than just a plain old PSA. And this is called the 4K score, or another competing product is a prostate health index. These are just blood tests. So with that in mind, let's go through a case study where we're trying to determine if a patient needs a biopsy or not. And I purposely presented this patient because he has lots of gray areas. We don't need genetic testing if a patient has a PSA of 100. We don't need genetic testing if there's a giant tumor on a digital rectal exam. We don't need genetic testing if there's a giant tumor seen on MRI. But it's really the very common garden variety, not black and white cases where genetic testing could be helpful. So let's say this is a patient, an actual patient. He's 55 years old. He has no family history of prostate cancer. His PSA was 6. PSA density was 0.17, meaning his prostate was not too big, not too small. So the density is kind of what we call borderline. One cannot feel a tumor or any nodule on exam. The prostate was normal size, and the ultrasound didn't show, it showed something, but that something was very small, only 6 millimeters. So what is one going to do with this information? Some doctors, I guess a lazy approach would say, oh, let's just do a biopsy, harpoon that person 12 times and see what happens, which can lead to bleeding, temporary impotence. It probably hurts a little bit. So we like to be a little bit more discerning and think through this before we jump to that recommendation. So this is where genetic testing can have a role. So one of the genetic tests that are on the market is called ExoDx. And this is a urine-based test to help us, guide us, whether or not a patient might have cancer that might be considered higher grade, or what we call clinically significant cancer. So this test might tell us, it doesn't tell us if a patient has cancer or not. It just tells us, does that patient have the low-grade cancer that doesn't need treatment anyway, so we don't need a biopsy since we're not going to treat, or the patient might have a higher grade cancer, which might might necessitate treatment. So it is it's officially, it's a genetic test, and the indication is someone who doesn't have a nodule. It's a urine test, and it's for men over 50 and who have a PSA of 2 to 10. So this is kind of the gray area, not someone who has a PSA of 20, for example. We talked about the criteria for testing. The way the test works is we collect simple urine. You have to wait 90 minutes since your last urine. So one collects the urine sample, and the sample is analyzed for these 4 genes and their quantity. And then they come up with the score. So with the score, basically, it's a yes or no score. So if the score is 15.6, below it, there's a good chance that whatever cancer, it doesn't tell us if he has cancer or not, but whatever cancer he may or may not have is probably low risk or not cancer. Or the patient, if it's above that score, there's a higher chance that they have what we call the clinically significant prostate cancer, and then you would go to biopsy. So this is kind of like the fork in the road based on the blood test, the urine test result to help us decide. A competing test is also a urine test, and this is this company is called SelectMDx urine test, and they look at different genes, and they also take into account the patient's age, PSA, size of prostate, and the digital rectal exam. So even if a patient had an abnormal exam, one can do this test. And this is another test to help us decide if a biopsy is needed, essentially, using these 3 genes. This is another way they try to show you what to do. Person has an abnormal PSA or an abnormal prostate exam, you do the test, and then you would decide if a person needs a biopsy or not need a biopsy. So these are 2 urine-based tests to help us decide if a biopsy is needed for someone who has not been biopsied. This test is, okay, so this is another test called Confirm MDX. And this is for a patient who's already had a biopsy that came back with no cancer or apparent no cancer. And we're trying to decide if the patient, typically, if someone has the same reasons that caused that person to have a biopsy in the first place, if the biopsy came back negative, we're still in this worry zone, and we still have to decide if a repeat biopsy needs to occur. One could still do the SelectMDx and the ExoDx urine test, but this specifically is another test in men who've already had biopsies. And let me just go through this middle picture real quick. So this is the prostate, and this is the 2 seminal vesicles. And when the traditional approach when one does a biopsy is to kind of sample throughout the prostate without targeting the biopsy, just kind of throwing out a big wide net and hoping to catch the cancer. So if a cancer is not too big, then these biopsies would miss the cancer. And on the surface, we would say, well, the biopsy is clear. The patient would be, have a big sigh of relief. But the truth is, there's a chance that the cancer was missed. And so doctors would say, well, we got to do another biopsy as the only answer, and which leads to, a lot of complications and discomfort. So before we do another biopsy, we could do this Confirm MDX. And this test is looking at these genes in the benign cores that were sampled. Remember, these cores do not have cancer in them, but these cores still have abnormal expression of these genes because apparently cores that are near cancer, even if benign, they have different expression of these genes. So one could look at these benign cores and then help us decide if a follow-up biopsy is needed. So using this confirm MDX test, if the test came back favorable, maybe don't do a biopsy, just keep a close eye on things. Or if the test came back abnormal, then repeat a biopsy or do more testing such as MRIs or ultrasounds. So this, you know, the last three products I talked about are for men who haven't had prostate cancer diagnosed, and to help us decide if a biopsy is needed. So the next category or indication for genetic testing is, well, once someone has been diagnosed with prostate cancer, can genetic testing help us with making a treatment decision? So the primary role of genetic testing at this point is to help us decide if a patient who has prostate cancer is a good candidate for active surveillance. And we'll go over the three tests, genetic tests below to help us decide. So typically, patients who are considered low-risk prostate cancer are people who have low-risk prostate cancer. We may consider them as candidates for active surveillance. And these are the traditional criteria for low-risk prostate cancer: a low PSA less than 10, no nodules or just a small nodule on exam. When the biopsy was done, there were only Gleason 3+3 disease or very small amount of Gleason 3+4 disease, a low number of cores involved, and a favorable genetic profile, which we're going to talk about. And on a MRI ultrasound, one can't really even see a lesion, or if they see a lesion, it's very small. So let's say all these factors were favorable, but the genetic profile was not favorable. Again, this is somatic testing, not inherited. Then one might tip the decision-making process into treatment if the genetic profile is not favorable. Or if the genetic profile is favorable, then we're more reassured that it's okay not to treat. So Prolaris is one of the genetic tests that we're going to go over. This is done using the biopsy slides that were removed from the prostate. And it's a test of 31 different, 46 different genes, and that helps them give a recommendation or a prognostic assessment of whether or not these genes are bad or good, overall. So they compare this to a group of men that they know the history of already and their outcomes, and then they basically look at a person's genetic genes and say, well, this pattern of gene expression looks more like a man who has bad prognosis versus looks more like a man who has a good prognosis. So let's see here. This is basically what we talked about earlier, help us decide if someone needs treatment or not. So these are the genes that the Prolaris looks at. And then they come up with this is a sample report. They come up with a score and a comparison to men in the low risk or low intermediate category, and then they'll tell you if this patient's genetic pattern of these 46 genes are they more or less aggressive than the standard person with low risk prostate cancer. So obviously, the higher the number, the gene pattern is associated with a more aggressive cancer. Another product is Oncotype DX. They look at, again, they look at a whole set of genes, primarily P10 loss, but and other genes as well. Again, they take a look at the cancer cells from the biopsy, and then they also will help us decide for these low intermediate risk patients what to do. So they look at 17 genes and they give a score of 0 to 100. And these are the genes that they look at. There is some overlap with the other test, Prolaris. And basically, and this is another way of telling us if a presenting us, how these tests help. Basically, on the surface, if a patient is considered low risk, after the Oncotype test, that person may be moved to intermediate risk, or that person may be moved to keep at low risk, or even moved to even very low risk. So the way they create the score is, after this is typically a report from Oncotype, and then they'll also tell you that based on these 17 genes, what's the chance that when one does prostatectomy, they'll find the favorable, good, low risk prostate cancer. A third test is called Decipher, and again, it's a summary. It's like the other test, but they give a little bit of different information. They predict the likelihood of having higher Gleason's grade scores. They also can predict the 5-year risk of metastases, and they can also predict the risk of death at 10 years from prostate cancer. Again, helps us decide not only if patients are good candidates for active surveillance, it may also help us clarify if the patient needs hormone therapy in addition to local therapy. And this is kind of telling you the same thing, who might benefit from having, surgery, radiation plus hormone therapy, or radiation alone or surgery alone. And this is the way their report comes out. And these are the things they're able to tell that the other testing does not tell. Again, this is based on the biopsy. So these 3 tests are, I would say, based on the recent data, I'm more inclined to do the Oncotype test, or the Oncotype test seems to be my favorite at the moment. But I've been pretty happy with Prolaris and Decipher as well. Another product that the Decipher company has is in someone who has had to help us assess after treatment what is one's prognosis based on the genetic expression of the cancer. And this is their Decipher post-radical prostatectomy test. Basically, they're taking a lot more sample because they're taking the prostatectomy sample, and it will help us decide if radiation urgently or later is helpful. So, and finally, they're working on a new genetic test that will even tell us if hormone therapy works, chemotherapy works, other drugs work, in addition to just telling us a prognosis. Now, this is experimental, so I wouldn't put any weight in this just yet. We need a little bit more data before we can trust what it is saying. The next role of genetic testing is how it can guide treatment. And we've made some inroads, but we're hoping for, there's a lot of upside for improvement. So this genetic testing is primarily used for men who have what we call castrate-resistant disease. And they've tried all the standard treatments such as chemotherapy, Zytiga, Xtandi, radiopharmaceuticals such as Xofigo. So is there a role of genetic testing in helping us find other treatments when someone has tried all the traditional treatments? Now, these three that we're going to go over, or these three companies and their products, are able to test either a biopsy tissue, like a lymph node or a piece of bone that has cancer in it, or more conveniently, just circulating tumor cells that can be just simple blood draw. So the first product is Guardant 360. It is able to give us information without a biopsy using a blood test. And they look at the DNA that is kind of floating around that is extracted by the cancer cells. And these are the genes that the Guardant 360 looks at. And of course, you guys see the BRCA1 and BRCA2. That's kind of the most important genes at this point. But let's see here. I would say after that, these genes in boldface are promising targets that are being, they're studying treatments to target these genes as well. Another product is Foundation One. In the past, they needed what we call, they needed tissue to do the test, but they do a lot more genes. They do 315 genes. And there's not only can it be helpful in identifying treatments for these people with abnormal genes, but also may help patients get into clinical trials and also maybe find men with cancers that may respond to immunotherapy. So this is their list of genes that they look at. And this is a typical report from Foundation One. This is a patient with colon cancer, but they could find the genes, they put it right here, and then they could even say, based on these genetic alterations, there might be some treatments that are FDA approved for that specific cancer, in this case, colon cancer. And there might be treatments that are used for other cancers that could be potentially used for this patient. And if there are no treatments, at least there's some trials that this patient can participate in based on the genetic mutation. And then they'll give you a list of clinical trials for one to participate in. And this is an example of a report. The foundation company then have a recent product, just like what we have for Guardant, which is they're doing peripheral blood without a biopsy. Because it's blood, there's less tissue, less cells. They analyze 62 of the most important, not over 300 cells, not 300 genes. So this is the primary, this paper came out about 5 years ago, and this is the first treatment that was devised based on a genetic mutation. And there's so these are called, olaparib is a class called the PARP inhibitors. And these are medications that specifically target men who have cancer, somatic or germline, that have a abnormal mutated BRCA gene. And it's actually not just the BRCA gene, There's a gene called ATM, and there's a Fanconi's gene and also a CHEK2 gene. So primarily there's 5 different genes that if mutated in the germline or somatic testing, they will have a pretty good chance of responding to this targeted therapy that traditionally was not even approved for prostate cancer. It's used for ovarian and breast cancer, but in men who have these genes, this ovarian cancer drug works for prostate cancer. And so now there are 2 drugs approved last year for that purpose. So the 2 drugs are olaparib and rucaparib, and I forgot to put the CHEK2 gene, but these are the genes that, if mutated, will respond to these 2 drugs. It also turns out that men with these gene mutations, when they do chemotherapy, they tend to respond to the chemotherapies that are devised from platinum. So there's one called carboplatin, for example. Another genetic gene or genetic test finding is what we call microsatellite instability. So basically, these genes, it's a test that looks at the genes and that shows that these genes are very unstable and they tend to mutate very easily. And if one has this type of gene or this type of finding, then one has a pretty good chance of responding to immunotherapy. Unfortunately, for prostate cancer, the likelihood of microsatellite instability is 10% or less. But if you happen to be that person with microsatellite instability, this drug can control the cancer for potentially years. So it's important to test for that. Another gene that helps us determine treatment is what we call the ARV7. So ARV7 is the androgen receptor gene, or the V7 section of the androgen receptor gene. And it turns out that people who have this mutation or variant, they don't respond very well to further hormone type treatments such as abiraterone and enzalutamide. So if one has this type of gene mutation variant, we may not offer these type of drugs as an option because we think that the response rate is fairly low. Now, luckily, this type of mutation doesn't tend to occur unless you've been treated with one or the other, and then these for a long time. And then one of the ways that cancer cells become resistant to these drugs is they develop this splice variant, and then they won't respond to the other drugs. So hypothetically, if a patient's been taking abiraterone or Zytiga for quite a while, and they start becoming resistant, this is when we test for the ARV7 variant. And if it came back abnormal, and there's about a 1 out of 3 chance, then we would say, let's not waste your time taking Xtandi or enzalutamide. Let's do something else, such as chemotherapy. Furthermore, hopefully in the future, the drugs that are being developed for people with this variant will show some positive data and perhaps approved fairly soon. So there's one called, made by a company called Arvinas in San Diego, actually, that we're waiting for results. So genetic testing, we've gone through there's four different scenarios where genetic testing is helpful for prostate cancer. And I'm just going to segue a little bit more about hereditary genetics. So hereditary genetics, again, is back to not somatic, but germline. So this is talking about the host DNA that is inherited from your parents. So one can check for that type of DNA, usually using blood or saliva. The the role of germline testing is, number one, it also helps with prognosis. I'll talk to you more about that in a minute. It could guide treatment, and maybe more importantly, help us screen or help us manage the offspring of affected patients more vigilantly if a patient has this germline mutation. And you could potentially, tell someone who's 35, whose parent has prostate cancer, and if the parent had an abnormal gene and passed it to their kids, you might be able to save his life earlier by telling him to get diagnosed, screened earlier. So currently, the germline mutation genes that are important are, again, the people with BRCA1, BRCA2 genes that they've inherited from their parents. So it turns out that if you have this gene, you're more likely to have a bad prostate cancer. So even if on the surface the cancer looks low risk, because you've inherited this gene, it might not be so safe to do active surveillance. There's a 50% chance that this can be passed on to your kids. And if you do have this gene, even as a man, you need to be aware that you or your kids could get breast cancer. You can't get ovarian cancer, of course, but you're also at higher risk of pancreatic cancer, I think at least 10-fold increase, and multiple different skin cancers. And again, just like somatic mutations, people with germline BRCA genes that they've inherited mutations, they respond to the PARP inhibitors if they get prostate cancer. Another set of genes are related to the Lynch syndrome genes, and these are the genes that I'm referring to. And these genes can be passed on from generation to generation. Again, 50% likelihood of being passed on to your kids. We don't think that we don't know completely, but it appears that if you have prostate cancer, and let's say it's low risk, just because you have this inherited gene mutation, it doesn't mean your prognosis is worse as opposed to BRCA patients. So in other words, if you're a candidate for active surveillance, you may still be a candidate for active surveillance if you've inherited these genes. These are other cancers that one needs to be aware of, that people who've inherited these genes are prone to: colon, stomach, liver, endometrial, skin, kidney, brain cancer. But interestingly, people with these genetic mutations that they've inherited, they do respond to immunotherapy drugs such as Keytruda or Opdivo and Tecentriq. So that's where it's important to look for germline mutations, not only as a prognosis or for your offspring and what other cancers to look for, but it also helps with treatment options. So these are the most common genes for that. At this point, like I said earlier, 1 in 10 men with prostate cancer got this because it was inherited. And primarily, it's still the BRCA ATM class of genes that make one prone to prostate cancer. But the Lynch type of genes, these right here, up to about 5%, are also play a role. And hopefully, as we find out more, and these are the genes that we're aware of, there might be even more genes that we'll learn that are associated with prostate cancer, and again, hopefully help us find some treatments as well. So that's where germline mutation is important. I didn't really cover germline mutations, when to do testing. Right now, the recommendations are anyone with high-grade disease, regardless of metastasis. Anyone with metastasis should get germline testing. And anyone whose family history looks suspicious. So in other words, if there's a lot of ovarian cancer in the family, a lot of breast cancer in the family, a lot of prostate cancer in the family, or even not a lot, but a few patients with those cancers, but who've developed those cancers at a abnormally early age. It's weird to have prostate cancer at age 40. So even if it's localized, not aggressive, if you're diagnosed at 40, you might want to get germline testing. And hopefully with more, this is part of the a lot of new treatments, hopefully in the future, will be based on what that person inherited or what that cancer the person has, what genes it is abnormal, what kind of abnormal genes. So this concept of personalized precision medicine is still what we're hoping for. So we're slowly getting there, but we definitely need a lot more research to help us hopefully tailor a treatment based on a person's or its cancer's genetic profile, rather than do surgery for everyone, do radiation for everyone, do chemo for everyone, do hormone therapy for everyone. So hopefully, after today's lecture, you have an idea at this point the role of genetic testing in prostate cancer, and we will definitely have a lot more information in the next 3 to 5 years. So I want to take this opportunity to thank everyone for attending this conference or this meeting, and we are open for questions.
Thanks, Doctor. That was a wonderful presentation. Certainly a lot of information that I have not been exposed to before, despite having both, I believe I have had both the Garden and the Foundation tests, as well as the urinalysis. I was first detected with the PSA test at age 39, although that being back in 2014, the doctor who read the results said, "Oh no, we don't pay attention to PSA anymore," and so nothing was done until I started developing symptoms when I was, I think, 43. But unfortunately for me, I also did none of the genetic tests came back as showing any indication of preference for treatment or any germline mutations, at least, that had yet been identified. But I do hope and expect that further research is going on to identify more and more of the genes that are related to especially the growth of cancers in younger people. Given the fact, and so to start out the questions here, so given the fact that I had these genetic tests done 3 years ago and nothing was found at the time, will these companies automatically inform doctors and patients should they find new information, or should we retake the genetic tests later on, or resubmit them, I guess?
I would say I would resubmit probably. Yeah, that's a good question. I'd probably resubmit after. It depends on how often they're adding new genes. So probably every 5 to 7 years.
Gotcha.
It goes back to it's not that quick, unfortunately.
Yeah.
And if you have, what they're also finding is you may have what we call a variant of unknown significance. So I'll use the I'll use a BRCA gene. That's the one that comes to mind. Typically, we've learned so much about the BRCA gene that we could tell you if you have the mutation, you have a bad situation. So, but we've learned that there are certain genes, more important, like the Lynch genes or the RAD gene, that the mutation there is a mutation, but not all mutations are bad. So that patient with mutation A is more prone to having Lynch syndrome and all those other cancers. And we got to worry about passing on to their kids. But you could have another Lynch gene that is mutated, but they don't think it's associated with badness. Mm-hmm. And so that's where more, if you already have a variant of unknown significance, we can't say, oh, you have this gene, you better watch out. We just don't know enough. And if you do have this gene, they should be contacting you when they learn more about the prognosis.
Excellent, excellent.
So
yeah,
it's important that if men have this variant of unknown significance, don't jump to conclusions that things are bad, but also be vigilant, and more information is needed.
Gotcha. I know that they at least did identify like what or one or more genetic mutations in the prostate tissue itself for me, but as opposed to what was in my normal germline. Yeah, but I'll have to review the results to see the specifics of it. So moving on to the questions that everybody in the audience had, are you able to see the Q&A there on your screen, or do you want me to read off?
Yes, I do.
All right, I'll just let you read off the questions and answer them then.
Okay, so first question is from Gene. Do most urologists do any of these genetic tests? I would hope so. I think if they do the genetic tests, it would be to help them decide if a biopsy is needed. And my estimation is, the more well-read, the more cerebral the urologist, the more likely they'll do the ExoDX and select MDX urine test and the 4K score. And so I would guess maybe about a third of urologists. I work with a lot of doctors at UCLA, and I've been impressed. They've been doing a lot of the genetic testing after biopsy. So Prolaris, Oncotype, Decipher, before jumping into making a recommendation. So they're getting better. In terms of metastatic disease, urologists manage metastatic disease sometimes, and I don't think they do these genetic testing. Oncologists are beginning to do it, because especially oncologists do it for other cancers as well. So there are a lot of products for other cancers relating to genetic testing. So more oncologists are doing that. Next question is anyone tracking genetic test predictions versus case outcomes? How many low-risk cases go on to metastatic or fatal outcomes? Is anyone tracking genetic test predictions versus? I don't think they test real time anymore. Once a test has been approved, it's based on these men have already been followed for 5 to 10 years after their test, and that's how they generate predictions whether or not a low risk case really becomes metastatic or fatal. So I'm not sure if there's any prospective testing going on. Next question is from Joel. For someone who is post-RP, under ADT and entering RT, would doing genetic testing for BRCA1, BRCA2 be indicated? Okay, so, and this person relapsed after radiation, after surgery. He has Gleason 9 disease. So the Gleason 9 would qualify and justify doing what we call germline testing to see if this patient has inherited a bad gene such as BRCA. And yeah, so the answer is yes. Whether or not one needs to do what we call somatic testing for tumor cell testing, or Decipher, or you did a Decipher post-RP, but whether or not one needs to do what we call the liquid biopsy, such as Garden and Foundation, at this point, I don't think so. I wouldn't necessarily, it wouldn't change treatment. So I would just do the germline testing. Let's see here. Next question is, which imaging tests are best and not locally available? I would say, a little bit, not off topic, but very important topic is imaging testing. And right now, we're most the most promising is the PSMA related testing, and there's and this is a category of PET scans that target the PSMA molecule, and there's two types of PSMA testing PET scans. One is using an isotope called gallium-68. And that's done at UCSF at UC San Francisco. I don't think there's anybody doing it in San Diego. And another promising PSMA test is what we call the PYL PSMA test, and that's done at Stanford. They basically they're able to detect the cancer better, meaning if there's something in the lymph nodes or the bones, there's a higher chance that one could find it, and there's a higher chance one could find cancer at a lower PSA. So to expand on that, in the olden days, you can't see the metastatic disease and with CAT scans and bone scan until the PSA is 10 or 20. Nowadays, we may even be able to see the cancer in a lymph node with a PSA of 0.5 with these experimental tests. In terms of what's available, the closest test we have to this PSMA PET scan is the Axemin or fluciclovone nuclear PET scan, and that's FDA approved, and that's approved for people who have relapsed after surgery or radiation therapy, and the scan has a higher likelihood of finding where the cancer is. So until the PSMA PET scans are approved, we have a decent PET scan called the Axemin. Okay, so next question is from Jack. How well do the results of the pre-treatment genetic tests correlate with another? I would say approximately 80%. And if I were to err on which one is the most sensitive or accurate, I'm leaning towards ExoDx a little bit over SelectMDx, but we still need more data to really have that, draw that conclusion. If allowed, I would do both, including a 4K score before a biopsy. In terms of, so this is pre-diagnosis genetic test. I'm reading wrong. So this is a pre-treatment genetic test. The testing for, which those tests are still helpful in terms of helping us decide for active surveillance, but more specifically, Prolaris and Oncotype we use for pre-treatment, whether or not to tell us to do active surveillance or not, or to treat or not to treat. I don't think there's any great genetic test that tell us how to pick which treatment. But any genetic test, you have to take it in conjunction with all the other parameters that we're blessed to have. So still, PSA testing, the PSA level, the PSA density, ultrasound and MRI findings are still very important. So not one parameter is going to help us make a decision for yay or nay. It's you put all the parameters together to determine if a patient's a good candidate for surveillance or not. Let's see, next question is, since I have prostate cancer, should I encourage my 51-year-old son to get a gene test, or should I initiate gene testing for me to guide him? He has not had a PSA yet. Okay, so if you have again, whether or not to do testing, first of all, let's talk about the patient, the current patient, in this case, Michael. Do you have, if you have what we call garden variety, low intermediate grade prostate cancer that was diagnosed at 60 or above, then, and you don't have much family history of prostate, breast, ovarian, colon, kidney cancers, then the likelihood that you've inherited a gene that gave you this cancer is low, and therefore there's a low risk for your son to get it. If you don't have it, your son's not going to get it. So we have to determine if you have a high risk of this inherited cancer syndrome first. If you do have if we did the testing and you do have the inherited gene, then of course your son needs to be tested because there's a 50% chance he has it. So a lot of it depends on the patient's own situation. Let's say you don't, it's unlikely you have germline inherited prostate cancer. You should still get your son tested at age 45 for prostate cancer, screen for prostate cancer with PSA, not necessarily doing germline testing. Any information on Prostavision by Bostwick Labs? They do the Prostavision, I think, does the PCA3 test. PCA3 is actually one of the components of the Select MDX urine test. So if I were to do a urine test, I would do Select MDX or ExoDX over the PCA3 Prostavision test. That's answer to Dawn.
Yeah, I'm using my wife's computer, so it's really deep.
Wow, Karen, you have a deep voice.
I know, sorry. My wife's computer has her name on it, so obviously.
It's like Kathleen Turner.
Yes. So I was trying to type all this out, but I thought maybe I could just ask it easier. I gave you a little bit of history. So my father had prostate cancer when he was diagnosed at 62, had radical prostatectomy and a little bit of follow-up radiation. He's now over 90 and doing fine, although obviously lots of after effects. I was diagnosed in 2014 through biopsy, and the biopsy showed just a few glands with Gleason 6. And then my urologist did 2 other follow-up biopsies, each one with one core less than 50% with Gleason 6. My density is less than 0.1. I have a PSA of 8. My prostate's rather large at close to 100. So I'm continuing on active.
And how old were you when you were diagnosed?
60.
Okay.
59.
Okay.
And so I've been on active surveillance since, just watching my PSA every, 3-4 months. And I did it, the last biopsy, they did an OncoDX test, and I think my score was like 18 or 17, which I believe is low risk.
Yeah.
So my question is well, 2. One is, I assume active surveillance is still a reasonable treatment. And then my next question is, my son, who is 40, should he be tested for this BRCA gene, or should I be tested for the BRCA gene, or what do you suggest there?
So, you don't fall into the criteria that needs BRCA, germline testing.
Okay.
So that would apply to your son also. Okay. I would say your son should start screening at age 45.
Okay.
And with regards, and I'm assuming there's not much breast, ovarian, pancreatic cancer in the family.
No, not to my knowledge. No.
Okay. And in your case specifically, just make sure you do some imaging. I mean, the multiple biopsies hopefully ruled out, missing a big cancer hiding under, that was hiding somewhere that the biopsies didn't get.
Yep.
But, you might want to do some imaging to make sure you don't have what we call a anterior transition zone cancer that one can miss on biopsies. You could do 100 biopsies. The needle just doesn't reach that far forward.
Sure.
So you might want to do that just to be sure. But if you've been monitoring for a couple of years and nothing has happened, you have the benefit of time, nothing bad happening for this long, argues strongly that you don't have something bad, because if you did have something bad, it would have kind of reared its ugly head within the first 2 years.
I see. And I have done, actually, I did a MRI with the 3T machine, I believe, or 3 Tesla.
Yep.
Just in this past year, and it showed nothing. I think it had, what do you call it, PRADs of 2 is all?
Yeah, that's basically nothing. Yeah.
Okay.
All right.
Okay, great. Well, thank you. I appreciate that. So nothing for my son other than here in the next 5 years, he should start getting PSA tests and DRE tests. Is that right?
Yeah. Now, some doctors don't even believe in DREs, but at least do a PSA.
Okay, great. Yeah, I forgot my DREs are all been fine, or nothing feels, you can't feel it.
Yeah, the problem with DREs is they're not teaching them very well.
Oh,
and
really?
People are not doing them anymore, because there was a period, same people who said don't do PSA testing anymore said don't do DREs anymore. And so it's almost a lost skill.
Huh. Well, do you believe in them if you are educated, right?
For sure. Yeah. Okay. I mean, there's so many times where I could feel something very subtle, but then I could then look for specifically on imaging or ultrasound, and it's it helps me guide my biopsies.
Right. Well, that's too bad. So in school, as they're educated, they're not educating them correctly on how to do a DRE. Is that what you're saying?
Yeah, exactly.
If I can just chime in on that one. Yeah, my primary care doctor had to Google how to do a DRE before he did mine. And
that's terrible.
Yeah. Well, he has a lot of issues associated with, not having sent my case on to a specialist. But on top of that, I also had 5 other doctors at least do DREs on me. None of them ever found anything abnormal in the DRE, while my PSA even rose to be 19 before my RP. So yeah, I am that 1 in 1,000 guys. Please get everyone that you can to have a PSA screening, and my recommendation is starting at 40 myself, but I'm not a doctor. I think we've had a few more questions come in too.
Okay. Let's see here. I have been on active surveillance for 14 years. My PSA is stable at 10 with a density of 0.12. And that's basically a PSA of 10 divided by a gland volume of 80. And I just had an MRI with nothing found. Oh, so PSA density of 0.12 is good, by the way. With nothing found. PIRADS 1, should I have genetic testing? If so, what test? So again, this person, Rich, been on active surveillance for 14 years. Clearly, your cancer can't be that bad if it's done nothing much for 14 years. So that's actually more powerful than any genetic testing. So no, you don't really need a genetic test to help guide your treatment. You don't need to, and this slow growing or not growing cancer is not one of those that you've inherited that are dangerous. So, and you don't have to worry about passing this on to your kids. So, unless you have lots of family history of other cancers and you want to see if you have a risk of developing a new bad cancer, then I don't think you need to do any genetic testing. Okay, so let's see here. Larry's asking, could you give the names of 2 2020 FDA-approved genomic tests from Garden and Foundation? Well, the Garden one, I think it's just called Garden 360. And the Foundation is Foundation ACT. Those are the blood-based tests. Do I have a preference? Not yet. I need to experience with both, but I started doing the Garden a couple years ago, and I'm starting the Foundation now, and I have a feeling they're going to be pretty equivalent. Okay, so the next question is, what is the Genomic Health's PGS score proper name, and would it be helpful for stage 4 metastatic prostate cancer? Genomic Health is the one that makes the Select MDX urine tests. And would it be helpful for stage 4 metastatic prostate cancer? I would say no. And next question is, have been given a Invitae germline test negative. Well, that's good. So that means you don't have you didn't inherit any known cancer-causing genes that you might have to worry about passing on to your kids. So at this point, I would say, whatever cancer you have, Jose, which I know you, it's not inherited. Probably isn't inherited. We just don't know all the genes yet. Given the negative germline test, does that mean there will be no benefit for somatic testing? No, the answer is somatic testing is genetic mutations that occurred spontaneously. So there still might be a role for somatic testing in certain cases. So that might help us guide treatment. But if we don't need any guidance with treatment, so whenever we do a test, we always have to decide, will the test change our treatment recommendations or considerations? So I don't remember your case specifically, but I wouldn't do a somatic test unless I think there will be some implications for treatment, because you don't have to worry about somatic mutations being passed on. So you do somatic testing only to help guide treatment. Next page, same person. I am on hormone therapy after a PET scan at Stanford that showed some micrometastasis in the lymph node. So let's see, radiated and does not show any recent thing on Axeman PET scan. So germline testing is indicated for anyone who's metastatic. So I'm glad your doctor did that. Again, somatic testing, let's say they uncovered somatic BRCA mutation. Will it tell me to give you a PARP inhibitor? No. Would it tell me to give you platinum chemotherapy? No. So I don't think it changes what we do at the moment. Now, if you relapse and hormone therapy stopped working, then we definitely need to do somatic liquid biopsy testing. At this point, if we do it, it's more out of curiosity. It's a few $1,000s to satisfy one's curiosity. Any more questions? You're welcome, Jose.
Yeah,
all right, so I guess
that does it for the questions. Doctor, that was a fantastic presentation and wonderful Q&A at the end there. Thank you very much for your time. We really do appreciate and enjoy you coming back to speak to us every year. I know that quite a few of our members do go up to Marina Del Rey to see you.
Yeah, thank you for having me, and thank you for the support you guys have given us over the last 10, 15 years. Yeah, I hope we could keep this going on all fronts.
Yeah, all right. Thank you, and you're welcome. Looks like Gene just joined. I think he might want to say something here.
How do I do that?
We can hear you.
You can hear you. I just want to add my thanks as a a longtime patient of Dr. Lamb, and now age 81. I'm here because of you, and it's because of all the kind of information you're transferring to these people helps them achieve what I have with you. Thank you.
Thank you, Gene. I hope we keep it up. We'll keep fighting this.
Bye now.
Thanks, Gene. Yeah, and I'm I guess, second level beneficiary of you, given all of the information that I've gotten from Gene and everybody else over the years. So thank you indirectly.
Oh, no problem. I'm glad you're doing well, Aaron. Congratulations.
Thanks. All right. Well, I think that wraps us up for another month. Just want to remind everybody, this is Movember, where men's health is foremost priority. And please do encourage everybody you know to get a PSA screen. And if you would, please do visit our website to give us a donation in honor of Movember. But otherwise, we will see you all in January. Thank you very much for your attendance today.